Good evening and warm welcome to all to the 13th episode of Occhio Healthscapes, which is a monthly video magazine of DigiConnect series of Enoch, that is Environmental and Occupational Health Initiative by AEOH or IFOH Delhi. The series was started in December 2020 to provide monthly update on local, regional, and global environmental and occupational health issues. Session is open to all stakeholders. Dr. Gajendra Kumar, President, Dr. Sandeep Sharma, Secretary, with Dr. Rajiv Kumar Jain, Vice President of AEOH Delhi, are the founders and backbone of this educative knowledge sharing platform, making sure this going strong for more than a year now. Dear participants, let's start the session with 2 minutes investment in health with Health Moment. I hope you all are comfortably, ergonomically seated, relaxed. Quickly, we all will try to stretch our arms. Right one goes upwards and back. Left one goes downwards and back. Try to touch the palms. Catch hold of the palms on the back. Yeah. Repeat now with the left arm up and back. Right one from down and back, trying to touch the palms. Do you notice any difference? Okay. So now, next one. Keep your left palm on the head. Start moving it anti-clockwise. Bring your right palm in front of your abdomen and start moving it clockwise. Okay. Left palm anti-clockwise and right one clockwise. How are you with it? Good. Excellent. So you have good coordination of mind and body. Please remember to invest in health. That is, invest your time for your health, if not doing it already. One last activity. Request all of you to close your eyes. Please concentrate on breathing. Inhale slowly, deeply through your nose. Keep your shoulders relaxed. Exhale slowly through your mouth. As you blow air out, purse your lips slightly to keep your jaw relaxed. Repeat the simple breathing exercise for few times, just few more times. Inhale slowly, deeply through the nose, shoulder relaxed. Exhale slowly through your mouth. As you blow air out, purse your lips slightly, but keep your jaw relaxed. Clean up the slate of your mind from all bothering thoughts. Dust away the stress. Now you're ready with a new blank sheet in the mind book. You're feeling peaceful, ready to focus on learning. Open your eyes. And now let's get started. So dear all, please note, this session is being recorded and will soon be shared on YouTube after the completion of the session. Please do visit Enoch DigiConnect webinar series on YouTube soon after the session. Subscribe, click like and notification icon. Also, please share further with your professional friends, group, health team in your company for their benefit of knowledge. There are already 137 recorded sessions available, and this will be the 138th recorded session. Please be noted, there will be 85th edition of DigiConnect Webinar Series 1, which is weekly video magazine at 6:30 p.m. tomorrow, that is 1st Jan 2022. So first day of new year. Registration link will be shared in the chat box soon. We welcome your questions for this session. Request you to put it up in the chat box to be addressed by Dr. Rajiv Kumar Jain soon after his presentation during Q&A time. Now, coming to the toughest part of my role as moderator is introducing the speaker of the session, Dr. Rajiv Kumar Jain. He is very well-known personality, a celebrity in our fraternity. Dr. Jain is currently working as Senior Consultant for Health in Indian Railways. He was Director, Health and Family Welfare in Ministry of Railways. He is based out of New Delhi. He has extensive work experience of more than 40 years, has more than 150 scientific papers been published and presented in national, international journals, conferences to his credit. He is a valuable member and contributing to many government advisory committee, NGOs, reputed national, international professional bodies, and public health foundations, institutions. He has been awarded with many reputed fellowships, orations at the conferences of national, international professional associations. So here is Dr. Rajiv Kumar Jain, a global personality. He speaks Hindi, English, and Chinese. I welcome Dr. Jain as speaker and soul of the session. Sir, stage is all yours. Thank you.
Thank you so much, Dr. Vidyakiran. I don't know how much I deserve the fine word that you've spoken, but all the same, on this eve of New Year 2022, we are starting the second year of OCU Healthscapes. And as you rightly mentioned, last Christmas, that is 25th of December, 2020, we started this initiative of OCU Healthscapes, a video magazine for updating the knowledge about local, regional, and international, global level updates on environmental and occupational health. And this will be the second volume starting from today. So if we look at the last 1 month since the last episode of OCU Healthscapes, a lot has happened. And we'll take stock of major events, major occurrences in the field of environment and occupational health during the past 1 month. We'll have the next slide, please. Yes, so we shall cover this wide range of issues in this episode of OCU Healthscapes. First and foremost, the story of India's falling fertility rates. Second would be the Delhi's air crisis, who pollutes and who suffers. Third issue we shall take up would be 10 key global health moments from 2021. Fourth topic will be how air pollution can shorten your life. Fifth would be an introduction to e-learning course on climate change and health. Next would be Healthy States, Progressive India, the report on the ranks of states and union territories. We shall also talk about all you need to know about new labor codes. Also, we shall cover how much is your government spending on your health. We shall talk little on what's blowing in the wind. Also, organizational best practices supporting mental health in the workplace from a journal, which is an international journal, that is Journal of Occupational Environmental Medicine. And also, we shall have a look at the HUL ending coal use across its plants in sustainability push in the years to come. So let's get on with the important observation for India. That is the story of India's falling fertility rate. And we shall cover this in 5 slides. The latest family health survey, that's NFHS 5, should put a lid on all the politically charged talk on population explosion in India. The fertility rate in India has been steadily coming down, with the 2019-21 survey putting it at an all-time low of 2 children per woman. Such a fertility level implies that India may finally have struck a population peak, a rate of 2.1, called replacement level fertility, is needed for each generation to exactly replace the preceding one. Uttar Pradesh, which was at the center of a recent controversy over a proposal to penalize with more than 2 children, saw its fertility rate drop to 2.4. Progress is on track, but it's still one of just 5 states that falls above the replacement mark. Let's take a closer look at what has shaped this demographic milestone for India. First is urban-rural gap. The urban-rural gap in fertility rates has narrowed over the years. On the graph you're seeing, from 1992 to 2019-21. Rural, it has fallen from 3.7 to 2.1. But in urban, look at the slide, 2.7 to 1.6. Rural areas have always had far greater fertility rates than urban areas, but that gap seems to be closing, with even rural India finally reaching the replacement level mark of 2.1 for the first time in the 2019-21 NFHS. Urban India had reached the mark in the 2005-6 survey. The gap between the fertility rates in the 2 geographies was 1 point in 1992-93, that is 3.7 for rural versus 2.7 for urban, which has narrowed down to 0.5 in the last 30 years. From a fertility rate of 5.4 in 1971, India's villages have come a long way. India would not have been able to bring its overall fertility rates in check had rural areas not shown improvement, as a majority of Indians still live in villages. Not just on the total fertility rate, the countryside has shown improvement on related fertility indicators, such as adolescent pregnancies and awareness and practice of family planning as well. That is what the data is showing. Let's look at the next slide. Second aspect is the fertility age. Above 30 women in urban India have been exceptions to the trend. As women marry later, fertility has been declining across younger age groups. Even in the 2024 and 25-29 brackets, when women are at their fertility peak, past data from the sample registration system has shown. However, the biggest change was noted in the 15 to 19 age group, with a marked decline in teenage pregnancies over the years. This should be seen with the fact that fewer women now report that they were married before the legal age of 18. The mean age of fertility also inched up from 26.5 years in 2011 to 28.4 years in 2018. The trend of marrying late is more common in cities, and this gets reflected in fertility data too. The median age of marriage was 19.8 in urban areas compared to 18.1 in rural areas. Shows the NFHS 4 data. This has been accompanied by a rise in fertility in women above 30 years in cities and towns, the major exception to declining fertility trends. Detailed NFHS data that would have age-wise fertility trends is not yet out. Let's look at the third dimension. That is the laggard states. For the 5 laggard states in the new survey, falling behind rest of India is a consistent trend. And which are those 5 laggard states? Number 1, Bihar, then Jharkhand, then Meghalaya, Manipur, and Uttar Pradesh. Bihar, Meghalaya, Uttar Pradesh, Jharkhand, and Manipur remain the only states with fertility rates above the replacement level and the national average. Bihar, which suffers from the highest fertility rate, is among the states that have actually seen the biggest declines in fertility since 2015-16. But since it had a fertility rate of 4.0 in 1992-93 compared to the national average of 2.8, in a way, it has improved much more than the rest of India in this period. However, the trend has not really been steady. Fertility actually showed an uptick between 1998-99 and 2005-6. Such lack of consistency is somewhat common in each of these 5 laggard states. To reach the last mile and attain population stabilization, such states need sustained investments in the education, health, and development needs of young people, said Sangmitra Singh, a health scientist at the Population Foundation of India. Let's look at the 4th dimension now. That is the underlying roadblocks. Languishing states are falling behind on one or the other contributing factor. Those 4 factors are women's literacy, women who had a paid job in the last 12 months, women of 20-24 years who got married before 18, and contraception use level among married women of 15 to 49 years. India's declining fertility is not a consequence of any top-down policy or coercive sanctions, but a sign of increasing prosperity. While it still has a long way to go, the country has progressed on a slew of indicators such as literacy, marriage age, and family planning, which directly or indirectly impact fertility. In 2018, the fertility rate was 3.0 among women who could not read, compared to 2.1 among literate women. The 5 laggard states also underperformed on one or the other contributing indicators. Bihar and Jharkhand performed worse on women's literacy, underage marriage, economic opportunity for women, and the practice of family planning methods. Uttar Pradesh fared poorer on 3 of these 4 indicators. Meghalaya and Manipur performed far better than the national average on the first 3 indicators, but lagged on the use of contraception. Now, let's look at the 5th dimension. That is the gender roles. Women continue to bear the burden of family planning. Data shows that even in 2021, 1 in 3 married women aged 15 to 49 do not resort to family planning. The burden of contraception still largely falls on women. As many as 38% married women rely on female sterilization to prevent unwanted pregnancy. In comparison, male sterilization is a rarity and has significantly declined since 2005-6 from 1% to 0.3%. The use of condoms is low at 9.5%, seeing a modest rise from 5.6% in the last 5 years. Even in urban areas, the use is only moderate. The last NFHS round finding that a large number of men see contraception as a women's business still rings true. Most programs operate from the perspective that women are contraceptive users, Sangmitra Singh said, suggesting that more male health workers be deployed who can be ambassadors of change to promote family planning uptake among men. So in these 5 slides, you see what are the contributing factors and what are the challenges to the population challenge that India has. But we have come a long way, and that needs to be underscored, recognized, and we should move forward. Let's look at the next slide and the next issue. Yes, Hindustan Unilever ends coal use across its plants in a sustainability push. The company has replaced coal with cleaner burning fuels such as biomass and diesel. HUL has transitioned factories it brought from GSK Consumer Healthcare to biofuels in April 2020. The factories which manufacture the Horlicks and Boost had boilers that were running on coal. The biomass the company uses includes stubble procured from farmers and sawdust. The transition of all factories into those fully using biomass as fuel will happen over the next 2 years. And that is a very climate friendly practice. I believe all companies in India, big or small, should start emulating the example of Hindustan Unilever Limited in India and across the world. In fact, India should lead the global efforts in this respect. Let's look at another aspect. Next slide. This is also true. Delhi's air crisis, who pollutes and who suffers? Let's look at this example, a real example. Monu, who is a 13-year-old living in a Delhi slum near the Yamuna River, was exposed on a particular day to an average of 150 microgram per cubic meter, which is very poor, of PM 2.5, while it is 35 satisfactory for 11-year-old Amia, who resides in an apartment in a colony in Greater Class 2 on Delhi. Thus ran a multimedia story by the New York Times in December 2020. Amia and her family have access to air purifiers at home and in school, even as her exposure to outdoor pollution is limited by air-conditioned cars, while the same does not hold true for Monu. Let's take this story forward. Next slide. This is the pollution exposure of 2 children in Delhi, and Monu is in red, Amia is in green. Look at the difference. Look at the difference. 6:30 a.m. to 23:57 a.m. And this PM 2.5 level in microgram per cubic meter, and you see the damage which environment causes on children's health. Next slide, please. Let's look at what pollutes, that is the sources of pollution in Delhi. Pollution is measured by the air quality index, which is calculated separately for 8 pollutants, that is PM10, PM 2.5, nitrogen dioxide, sulfur dioxide, carbon monoxide, ground level ozone, ammonia, and lead. And the highest of these indices is reported as AQI for that particular day. Since these pollutants are related to each other, controlling one will help control the others too. Instead of tracking all pollutants, the policy could focus on PM 2.5, which measures all aerosols under 2.5 micrometers in diameter. That is, if you see the real situation, our hair is almost 30 times as thick and has contributions from all the other gaseous components. The chart that you are seeing in the bottom part of the slide shows the source attribution for PM 2.5. 3 major contributors to pollution from the consumption side are transport, that is private and public, fuel and electricity, and construction. Based on these numbers, 60% of AQI is contributed by consumption. But if these are the major sources, shouldn't AQI remain similar through the year? It gets worse in winters, not only because of stubble burning, but also among other factors, that is natural factors, such as Delhi being shaped as a bowl, which traps pollutants for far longer as a result of the wind slowing down during the winter months. Let's look at the second part. Who pollutes? It is beyond obvious that the affluent classes, as a result of their consumption patterns, pollute more than the poor. But is it possible to quantify their respective contribution? It is difficult to provide an accurate measure, but an approximate one can be derived from the National Sample Survey. NSS consumption data, which provides data on consumption of different deciles. We categorize different commodities in the consumption basket from the 2011-12 Consumption Expenditure Survey of the NSS according to the above mentioned 3 major sources of pollution. Based on the consumption basket of each decile and weighing them according to the shares of these 3 sources, we arrive at each decile's share in total pollution. The chart on the right is showing that the richest 10% of the population pollute 10 times as much as the poorest 10%. Imagine the contribution the rich make for making the poor people's life more miserable. Let's look at the third dimension. Who suffers? While all residents face the adverse health effects of pollution, the poor are more vulnerable to its ill effects than the rich. This class difference comes out starkly in pollution-related data, that pollution-related death data. NFHS does not generally provide reasons for death, but in one of its rounds, the second one in 1998-99, it had a question on the cause of death, and 2 respiratory ailments were listed, both of which have a direct link to pollution. The first is asthma and second is tuberculosis. This paper, published in World Development, measured the difference in mortality across income groups. We clubbed the classes in NSS to correspond to the NFHS category, using the above mentioned paper's methodology to present a class funnel of contribution to the problem and its result effects. While the high income category pollutes the most, you look at the chart on the right, which shows the burden of death falls unduly on the bottom. Those who contribute least to the problem bear the maximum brunt of it. And that is the biggest tragedy. Yes. Now, we know who pollutes and who suffers, but we should also understand what is to be done. The pollution crisis needs a systemic solution. Lockdowns are no solutions, nor are they symbolic odd even schemes or red light on, engine off placards at the traffic signals. We need to hit at the source of it, commodities that pollute and the classes that consume most of it. But how does one do that? Some of these solutions are low-hanging fruits. Energy efficiency in India is one of the lowest in the world, which means for every unit of consumption, a lot of energy is wasted. To give an example, air conditioners running in houses or offices with poor or no insulation would invariably mean higher consumption of electricity and more pollutants in the air. Government of India estimates show that at least 30 to 40% of energy can be saved purely by retrofitting, insulating buildings and offices, steps which can be incentivized through policy. Some other solutions are more difficult, but much needed. Delhi needs to consider a pollution tax. It can be levied at the source of energy usage, that is fuel and electricity, since that is the easiest to implement. Additionally, yearly excise tax on cars, high parking charges, as well as congestion charges can be implemented. A part of this tax needs to be spent on overhauling the public transport infrastructure of the city with dedicated bus lanes to ensure reliability, a much larger fleet of buses, cycle lanes to ensure last mile connectivity, and pedestrian safe pavements. Driving cars should become more expensive, but only after a better, cleaner, and most importantly, reliable alternative has been provided. The problem with such a tax is that the burden will fall unduly on the poor, since they will be paying the same price as the rich for a given commodity. To address this regressiveness, one could implement a pollution tax and a clean dividend policy. The tax collected after deducting the infrastructure spending is distributed equally among all citizens of Delhi as a clean dividend. The poor will gain at the cost of the rich. Let's say a pollution tax of 100 is collected, of which the rich have contributed 80, since their overall consumption is much higher than the poor, who contribute 20. After spending, say, 40 on infra, when the remaining 60 is distributed as a clean dividend equally, they get 30 each, which means a net gain of 10 for the poor. In reality, this net gain will be even higher, since their proportion in the population is generally higher. This clean dividend can be in cash or kind. If implemented in kind, it could be in the form of access to commodities such as food through ration shops, electricity, health, and transport up to a certain amount. We suggest the implementation of pollution tax to be staggered and only after the infrastructure in place. This is for two reasons. The onset of a sudden high tax may not be acceptable to most people, as was the case in France with the yellow vest movement. However, if people receive benefits from day one, including infrastructure development, and are then presented with a gradual tax, they will be more likely to buy into it. Delhi residents, especially the wealthy, need to be convinced that current and future inhabitants of the city, especially the children, will have a healthier life with the implementation of such a clean and just policy. So, if it appeals to you, then you must spread this message of the solution to a problem which is equitable, which can be a model for other cities in India and abroad. Next slide, please. Now, we are on the last day of 2021. And here, we shall now review the 10 key global health moments from 2021. Let's look at the first global health moment. It has been a year of colossal efforts in global health. Countries battled COVID-19, which claimed more lives in 2021 than in 2020, while struggling to keep other health services running. Health and care workers have borne the lion's share of these efforts, but often receive little recognition or reward. Life-saving COVID-19 vaccines, tests, and treatments were rolled out, but overwhelmingly in the richest countries, leaving many populations unprotected, especially in lower-income countries. Across other health areas, from diabetes to dementia, there have been both setbacks and hard-won success. So we present to you now 10 global highlights from 2021, including a few issues you might have missed. Next slide, please. Innovation and inequities in the COVID-19 response. Let's look at the video first and then review this global moment of 2021. A short video which will talk about this issue.
COVID-19 has affected us all, but tests, treatments, and vaccines still aren't available to everyone who needs them. This inequality is making the pandemic last longer. COVID-19 will cause 5 million more people to die needlessly and cost the world over $5 trillion by 2026. But we can turn it around if we act together. With an investment of $23.4 billion, the Access to COVID-19 Tools Accelerator can support countries to reach their vaccination goals and achieve the 70% coverage target, ensure 120 million COVID-19 patients have access to treatments, perform at least one test per 1,000 people daily, and keep 2.7 million healthcare workers safe with personal protective equipment. Expanding access will save the lives of millions, ensure global health security, and drive economic recovery. It's time for governments to fully fund the ACT Accelerator for a more equitable, secure, and healthy world for all.
So I feel this is the biggest global health moment for 2021. Inequities in access to health tools came into even sharper focus this year. Over 8 billion COVID-19 vaccine doses have been administered worldwide, but by the end of November, only 1 in 4 African health workers were fully vaccinated. A mere 0.4% of tests globally have been carried out in low-income countries. Driving efforts to end the COVID-19 pandemic, WHO has led the charge for equity. We have set global vaccination targets and emphasized that the priority in every country and globally should be protecting those most at risk, such as health workers and elder people. As of 20th December 2021, WHO have validated 10 COVID-19 vaccines as safe, effective, and high quality, and continuously updated the therapeutics guidelines reflecting the very latest clinical insights. Collaboration is key to the WHO's COVID-19 response. The world's best scientific brains came together to ask and answer the critical research questions needed to tackle COVID-19 under WHO's research and development blueprint. The ACT as accelerator halved the cost of COVID-19 rapid tests for low and lower and middle income countries and procured over 148 million tests. Its vaccines arm, that is COVAX, delivered over 750 million doses globally, despite substantial challenges such as vaccine hoarding and insufficient transparency from manufacturers. Throughout this uncertain year, WHO partnered closely with countries on preparing for rollouts. WHO has also launched an mRNA technology transfer hub initiative and in supporting a South African manufacturer in bringing the know-how, data, and technology together to develop production capacity to serve the region, providing a great example of a transparent global non-exclusive agreement. The COVID-19 Technology Access Pool announced its first license, which will allow all countries to manufacture a serological test developed by the Spanish National Research Council. As WHO's COVID-19 response continues apace, so do WHO's preparedness efforts to future outbreaks. With Germany, WHO opened a hub for pandemic and epidemic intelligence in Berlin. With Switzerland, WHO launched the first facility in global biohub system for rapidly and safely sharing pathogens, which will help assess risks and enhance global preparedness. Globally, there have been over 100 intra-action reviews for countries who have used this tool to evaluate their COVID-19 response and strengthen them in real time. In parallel, the pilot rollout of universal health and preparedness reviews has successfully recruited countries to learn from each other in assessing the readiness for the next pandemic, while providing for and promoting the overall health of their populations. Let's look at the second aspect. Emergencies emerge and persist. As the pandemic raged on, WHO and partners continued helping communities caught up in protracted humanitarian crises, such as those in Yemen and Syria, while responding to emerging ones in Afghanistan and northern Ethiopia. In Yemen, COVID-19 has further strained a health system already beset by conflict and other disease outbreaks, where only half of the country's healthcare facilities are reported as functional. WHO has helped millions by supporting essential health services and therapeutic feeding centers to treat children with acute malnutrition. In response to the pandemic, WHO worked on the construction of oxygen production stations, capacity building for healthcare workers, provision of medical and protective equipment, and bolstering laboratory and testing capacity. After more than a decade of crisis, needs in Syria are greater than ever. WHO stepped up with the deliveries of medical supplies and by working with partners to provide mental health support. Currently, the world's largest humanitarian emergency, Afghanistan is contending not only with COVID-19, but also acute watery diarrhea, dengue, measles, polio, and malaria. WHO has shipped over 414 metric tons of life-saving medical supplies since 15 August 2021, and with partners vaccinated 8.5 million children against polio through a November campaign. Severe hardships, including a lack of fuel, food, and medicine, also afflicted people in northern Ethiopia. WHO provided over 367 metric tons of humanitarian cargo to Ethiopia to date to provide relief to hundreds of thousands of families. Together with partners, WHO also launched a campaign to vaccinate 2 million people against cholera in Tigray region. WHO also supported mobile health and nutrition teams to deliver services to internally displaced people in conflict-affected Afar, Amhara, and Tigray regions. Now we go to the next aspect. Yes, next slide. Tackling health service challenges. Once in a generation crises have outsized ripple effects. The pandemic is likely to halt 2 decades of global progress towards universal health coverage, having triggered the worst economic crisis since the 1930s and badly disrupted health services. According to new data launched this year, 23 million children missed out on routine vaccines in 2020, the largest number in over a decade, increasing risks from preventable diseases like measles and polio. Over half of the countries WHO surveyed between June and October 2021 reported disruptions to services for diabetes, cancer screening and treatment, and hypertension management. As we navigate these challenges, universal health coverage remains WHO's North Star. Even before COVID-19, the world was falling short of the target of to see 1 billion more people benefiting from universal health coverage, as 500 million people were pushed still further into extreme poverty because of payments they had to make for healthcare. The situation will only be worse as a result of the pandemic. So we must redouble our efforts to make health for all the rallying cry of the recovery. COVID-19 has exposed the limits of the resilience of health system, underscoring the need to build them up to better deliver on both universal health coverage and health security. All countries should invest in primary health care, the health and care workforce, health infrastructure, medicines, and other health products, and strengthening social protection mechanisms. For its part, WHO is bolstering health services at this pivotal moment. For example, through WHO's collaboration with partners on achieving the Immunization Agenda 2030 strategy. WHO also facilitating big picture thinking of the way forward by convincing experts to look at how to fund health for all and ensure that medical breakthroughs serve the common good. Shortly after Universal Health Coverage Day, WHO marked the agreement of the Geneva Charter for Well-being, which signals the need for a paradigm shift towards prevention and equipping people to take control of their own health. And that's good news for occupational health practitioners. Next slide, please. Yes, greater contributions by and challenges for women. If health systems and services have weathered the storm of the past 2 years, it is in no small part due to the huge sacrifices of the women who represent 70% of the health and social workforce. WHO's Year of the Health and Care Workers campaign has called for protecting them and investing in their work environments and education. The WHO Academy represents a major investment in the latter area, that is education. Women also played a leading role in driving scientific breakthroughs. WHO is committed to dismantling barriers to women's participation in science so more can participate in pushing the boundaries of knowledge and safeguarding public health. Committed to championing women as decision makers and leaders, WHO signed a MOU with the Women in Global Health Network and made multiple commitments to women's empowerment and equality at the Generation Equality Forum. WHO has also moved to rectify past injustices, awarding a posthumous award to Henrietta Lacks, who in 1951 had tumor samples taken without her consent during a treatment for cervical cancer. Lacks' life was cut short at the age of 31, but her legacy lives on. Her calls have contributed to nearly 75,000 studies, paving the way for advancements from HPV and polio vaccines to medications for HIV/AIDS and breakthroughs, including in vitro fertilization. But women and girls are facing new or heightened health challenges, as the COVID-19 pandemic has exacerbated existing inequalities and disrupted access to vital health and support services. The largest ever study on the prevalence of violence against women shows that almost 1 in 3 women globally have been subjected to physical or sexual violence by an intimate partner or sexual violence from a non-partner. Exposure to violence at home likely increased during the pandemic. WHO resources aim to help health workers better support survivors, while new research highlights the urgent need for policies that prioritize violence against women as a public health threat. To address health challenges that particularly affect women, WHO is working to help countries eliminate cervical cancer, releasing new guidelines on cervical cancer screenings, and pushing for equity in access to vaccines, screening, and treatment. The WHO also launched a groundbreaking initiative to tackle breast cancer, aiming to significantly reduce deaths from the disease. After this important aspect of global health movement of 2021, let's look at a new aspect, that is malaria vaccine, a beacon of hope in the fight against a range of infectious diseases. Just as health workers have been guiding lights in these difficult times, so has the transformative potential of science. WHO's recommendation of the widespread use of a malaria vaccine for children at risk, particularly in sub-Saharan Africa, marked a milestone moment for child health and malaria control. The recommendation was based on the results from an ongoing pilot program of the RTS-S vaccine in Ghana, Kenya, and Malawi that has reached more than 800,000 children since 2019. The vaccine has reinvigorated the fight against malaria, which claimed the lives of over 600,000 people in Africa in 2020. Children under the age of 5 represented 80% of these deaths. Even before the pandemic struck, there were signs that after years of phenomenal gains, progress was stalling. Other major achievements relating to immunization include the introduction of a licensed Ebola vaccine and launch of a landmark new global plan to tackle meningitis. Meanwhile, WHO released new evidence that more countries are following WHO's advice on the steps to take when HIV drug resistance reaches critical thresholds. This is an important step forward in the global fight against antimicrobial resistance, about which WHO continues to raise the alarm, calling for action on innovation and within the food system. Next slide. Next aspect, of course, this is the vaccine for malaria, which is being used now in sub-Saharan Africa. Another dimension, another global health moment of 2021 was a new boost to the fight against diabetes. With 2021 marking the 100th anniversary of the discovery of insulin, WHO launched a global diabetes compact to speed up action on the prevention and treatment of diabetes, bringing together people living with diabetes, academia, civil society, the business community, and more. The compact aims to reduce the risk of diabetes and ensure that all people diagnosed with the condition have access to affordable and good quality care. A new report published in November 2021 highlighted that insulin, a life-saving diabetes medicine, remains out of reach for a high proportion of the people who need it. WHO is working on a number of fronts to increase access to insulin and related products, with a priority to ensure uninterrupted production and supply of human insulin. The inclusion of insulin analogs on WHO's essential list of medicines opens the door to their pre-qualification, which could increase competition and potentially reduce the prices. WHO's work on diabetes is just one part of WHO's comprehensive efforts on non-communicable diseases and mental health. This is no small undertaking, given that NCDs claim the lives of 41 million people each year, equivalent to 71% of all deaths globally. Depression alone constitutes a leading cause of disability worldwide. Next slide, please. Tobacco use pen. At this juncture, I again would like to share a video on tobacco use, which shows how much can be done if one makes efforts. Let's have a look at the video.
Quitting this habit because I don't want to depend on something that is so harmful as a coping mechanism.
كمان لما نكون قاعدين في مع الأصدقاء أو المقربين اللي ما بيدخنوا كانوا يتضايقوا من ريحة الدخان. حتى أنا كمان كنت إني دائما أشم في ريحة الدخان.
也算是医学类的科学，竟然是一个吸烟的人群，这一点对于我来说也是出乎意料的，对于很多人来说都感到很吃惊。
I believe that the decision to quit smoking is a very personal one. With the difficult year that we've been through, the whole year of being locked down and a pandemic, I somehow started to get philosophical in a way, and then I just realized that there are small things that deciding my life in a very, very big way.
¿Y sabes qué es lo que te genera ese querer dejar de fumar? Pensar en tus hijos, en tu familia. Fueron muchos años de fumar, ya es momento de pensar en cambiar esa situación.
Over the next 2 weeks, I will be quitting smoking and taking you on a journey to what that's like, the challenges, the ups and the downs.
I think I'm not the only one if I say that I tried to quit many times.
La verdad que estuvo un desafío porque no es fácil, pero es posible.
Quitters are winners. Now, let's examine the reality of tobacco. As a fateful choices for health and preventing NCDs, impressive numbers of people are deciding to stop smoking. Between 2000 and 2020, the number of people using tobacco dropped by 69 million, from around 1/3 of the global population to under a quarter. 2 years ago, only 32 countries were on track to lower tobacco use by 30% between 2010 and 2025. Now, 60 countries are on course to achieve the target reduction. Look at the quantum jump from 32 to 60 countries. Progress is fragile, however, with the tobacco industry having exploited the COVID-19 pandemic to build influence with governments in many countries. The Conference of the Parties, that is COP9, to the WHO Framework Convention on Tobacco Control, that is FCTC, endorsed a declaration on recovery from the COVID-19 pandemic and also established a funding mechanism to strengthen global tobacco control measures. Tobacco users who would like to quit can draw on resources shared via WHO's Commit to Quit campaign, including the Quitter's Diaries, charting personal journeys in stepping away from tobacco. Next slide, please. India ranked second out of 199 countries in deaths in 2019, which can be attributed to air pollution. And you look at the reality, India ranked second. If you look at Egypt, 90,600, Nigeria, 68,500, Ukraine, 42,900, Russia, 73,900. Only China was higher, that is 14,24,000, and India had 9,79,700. These are the deaths in 2019, which can be attributed to air pollution. China ranked highest with more than 14 lakh deaths. Let's look at another aspect. Next slide. How much is your government spending on your health? India ranked 152nd out of 188 countries in the current health expenditure per capita in 2019. India had $64, while Switzerland had 9,666, which is the highest. USA had 10,921. Canada has 5,048. And a country like China also has $535. Japan has 4,360. Australia has 5,472. And Norway has 8,000. Even a country like Burundi has $21. Congo had $21. South Sudan had $23 per head. And Madagascar had $20. Pakistan had $39. Let's look at another issue. How air pollution can shorten your life. Air pollution is a mixture of natural, man-made gases and particles in the air we breathe. These include particulate matter, such as PM2.5 and PM10, nitrogen oxides, sulfur oxides, ground level ozone, carbon monoxide, and volatile organic compounds. And indoor activities like tobacco use, dung, the chula, smoke, coal, and wood. And outdoors, wood burning, excuse me, construction dust, vehicle exhaust, and industrial pollution. Next slide, please. How does it affect the human body? Fine particle 2.5 has the capability to get deep into the lungs and also into the bloodstream, causing respiratory and cardiovascular illnesses, causing lung cancer, pneumonia, upper and lower respiratory infection, airway inflammation, diseased lung function, diabetes, high blood pressure, premature birth, low birth weight, preeclampsia, skin aging, myocardial infarction, heart failure, heart rate vulnerability, and stroke and cognitive development, and stress and anxiety. These are the range of health impacts of air pollution. Next slide, please. What is particulate matter? Particulate matter, that is PM, is a mixture of solid or liquid particles suspended in the air. PM10 primarily comprises dust, while PM2.5 is a byproduct of combustion, whether it could be natural, that is forest fires, or man-made, that is vehicles, industrial emissions, or biomass burn. What can you do to protect yourself during high pollution events? If you have respiratory ailments such as asthma and bronchitis, keep your medication handy. Check air quality before stepping out. Use anti-pollution protective masks. If you and your family members experience any discomfort while breathing, inform the doctor. 2.1 million deaths from air pollution happened in 2015. This is the high burden of disease. Ambient air pollution caused 1.2 million, that is 12 lakh deaths, and deaths due to indoor air pollution were 9 lakh. Who is vulnerable? People with existing respiratory or cardiovascular health issues, infants, children with asthma or bronchitis, and elderly persons should avoid exposure on poor air quality days. What can we do to help? Use public transport, you reduce the electricity usage, and prevent waste burning and plant trees, and last but not least, avoid use of solid fuels for cooking. Another aspect we want to share today is a new course, that is the e-learning course on climate change and health. Applications are being accepted till 5th of January 2022. The Center for Environmental Health is organizing an e-learning course on climate change and health with 3 other international collaborating institutions, namely University of Eastern Finland, Kuopio, Finland, University of Port Harcourt, that is Port Harcourt, Nigeria, Villanova University in the state of Pennsylvania, Villanova, United States of America. This e-learning course is ideal for graduate and postgraduate students in medicine, nursing, public health, and allied disciplines, including nutrition, social, behavioral, and environmental sciences. The course will be held from 17 January to 30th April. The course will be delivered with joint faculty from the 4 mentioned institutions and students drawn from these 4 countries at graduate and postgraduate level. This e-learning course is an interdisciplinary course. It is an international course. It examines the impact of climate change on human health in Finland, India, Nigeria, and the US. Students from different regions of the world, Finland, India, Nigeria, and US, will study climate health science, health impacts of climate change, strategies of mitigation and adaptation, local, national, and international policy, and real-time ground-level climate realities from each participating nation. This e-learning course is ideal for graduate and postgraduate students in medicine, nursing, public health, and allied disciplines, including nutrition, social, behavioral, and environmental sciences. The course will broadly cover the topics of climate science, examining and analyzing the climate data, climate vulnerabilities, people and system, migration of people and conflict, extremes of temperature, heat and cold, flooding and droughts, non-communicable diseases, infectious disease, food sustainability, health system preparedness, response, resilience, public health impact and response, national and global policy and program related to mitigation, adaptation, and resilience. The teaching will cover a combination of lectures and video presentations, suggested reading, and group activities, besides providing a forum for interactive exchange with students from 4 countries. So it'll be worthwhile if you have interest in climate change and health, with the background of an interest in public health and global health and survival of mankind, then think of joining this e-learning course. Faculty will be Ruth McDermott Levy, who is Associate Professor and Director of Center for Global and Public Health at the College of Nursing, Villanova University, and Mbe Okon, who is Head of Department of Community Medicine, University of Calabar, Nigeria. Then from India is Purnima Prabhakaran, who who is Head of Environmental Health, Additional Professor, Deputy Director, Center for Environmental Health, Public Health Foundation of India. Risha Sharma, who is a research scientist at the Center for Environmental Health, Public Health Foundation of India. Ambrish Datta, who is Additional Professor of Epidemiology, Indian Institute of Public Health, Bhubaneswar, Public Health Foundation of India. Henel Turunen, Professor, Head, Department of Nursing Sciences, University of Eastern Finland. And Lori Kosmanen, Lecturer, Department of Nursing Science, University of Eastern Finland, Kuopio, Finland. The course will be conducted through an online portal called Yellowdick. Now, we take a look, an overview, in short, of the Healthy States Progressive India, a report on the ranks of states and union territories brought out by Niti Aayog, World Bank, and the Ministry of Health and Family Welfare Government of India. About Health Index Round 4 of 2019-20, released on 24th of December 2021. Next slide. In 2017, the National Institution for Transforming India, that Niti Aayog, in collaboration with the Ministry of Health and Family Welfare and the World Bank, initiated an annual health index for tracking overall performance and incremental performance across all states and union territories. The objective of the annual health index is to track progress in health outcomes and health systems performance, develop healthy competition, and encourage cross-learning among states and union territories. Health index scores and rankings for states and UTs are generated to assess incremental performance, year-to-year progress, and overall performance, that is current performance. It is expected that the exercise will help drive states and UTs' efforts towards achievement of health-related sustainable development goals, including those related to universal health coverage and other health outcomes. Health Index is a weighted composite score incorporating 24 indicators covering key aspects of health performance. Health Index comprises of select indicators in 3 domains. First, health outcome. Second, governance and information. And third, key inputs and processes. Their importance and availability of reasonably reliable data, at least annually, from existing data sources, such as a sample registration system, civil registration system, and health management information system. A composite index is calculated as a weighted average of various indicators focused on measuring the state of health in each state and UT for a base year, that is 2018-19, and a reference year, that is in the 2019-20. Given the focus on performance, the health outcomes are assigned the highest weight. 4 rounds of health index have been undertaken, and this report relates to the 4th round for generation of ranks to ensure comparability among entities. That is classified into 3 categories, that is larger states, smaller states, and union territories. In this round, all the states and UTs participated except West Bengal, and the union territory of Ladakh was not included due to non-availability of data. The Health Index Round 4, 2019-20 does not capture the impact of COVID-19 on health outcomes or any of the other indicators, as the index performance relates to base year 2018-19 and reference year 2019-20, largely the pre-COVID period. Next slide. The learnings from the previous 3 rounds of health index were taken into account to develop the Health Index Round 4, that is 2019-20. For the 4th round of health index, review of indicators was undertaken, and 3 new indicators were added for larger states. These are maternal mortality ratio, proportion of pregnant women who receive 4 or more antenatal checkups, and level of registration of deaths. The indicator relating to community health centers and sub-district hospitals with grading of 4 points or above was dropped, and the definition of 2 indicators, the one related to data integrity measure and second related to quality accreditation of public health facilities, was refined. Next slide. Among the largest states, Kerala, Tamil Nadu, and Telangana emerged among the best 3 performers in terms of overall performance. Next slide, please. And here you see Uttar Pradesh, Assam, and Telangana are at the top with the incremental change. If you see overall reference here is 19, 12, and 3, but if incremental rank, top 3 are Uttar Pradesh, Assam, and Telangana here. Next slide. Smaller states, you find incremental top 3 are Mizoram, Meghalaya, and Nagaland. Next slide. This is Union Territories. Overall reference here. The best three are Delhi, Jammu Kashmir, and Lakshadweep. And Delhi at the top. Next slide. For a vast majority of states and UTs, there has been a shift in the overall performance ranking from base year of 2018-19 to reference year 2019-20. Among the 19 largest states, 4 improved their rankings, while 5 states deteriorated in their ranking from base year 18-19 to reference year, and 10 states retained their base year. Next slide, please. This is what is shown. Improved rank larger states is Telangana, Gujarat, Punjab, and Assam, and smaller states Mizoram, Sikkim, and Meghalaya, and Union Territories Dadra Nagar Haveli, Lakshadweep, Delhi, and Jammu Kashmir. The gap in the overall performance between the best and the worst performing larger states and Union Territories narrowed in the current round of health index, while it increased for the smaller states. Next slide. Nearly half of the states and UTs did not reach the halfway mark in the composite overall index score. And despite good performance, even the top ranking states and UTs could benefit from further improvements. Next slide, please. The incremental changes in health index scores from base year of 18-19 to reference year 19-20 varied significantly across states and Union Territories, with a vast majority of larger states registering at least some improvement. This is what you see. Positive incremental performance, larger states, 19 of them. Smaller states, 8, out of which 4 showed positive incremental performance. Union Territories out of 7, 5 have shown positive incremental performance. Next slide. This is only 5 larger states and 2 smaller states showed good overall performance and continue to improve on their health index score from the base year 18-19 to reference year 19-20. Next slide. In the governance and information domain, majority of states and UTs registered an increase in index scores from base year 18-19 to reference year 19-20. Next slide. There are wide disparities in the key inputs and processes domain index scores across states and Union Territories. Next slide, please. Among the largest states, Telangana is the only state that demonstrated strong overall performance as well as incremental performance, while Rajasthan reported weak performance on both counts. This is what is shown in the health outcome domain and governance and information domain and inputs and processes domain. And best performance is Telangana and worst performance is Rajasthan. Next slide. This is on each parameter, you're seeing how best performing state and worst performing state have performed. In case of smaller states, Mizoram emerged as the best performer and Arunachal Pradesh and Manipur as the worst performers, both in terms of incremental and overall performance. The incremental performance on various indicators varied widely across larger states between the base year 18-19 and reference year 19-20. There is a general negative correlation between the health index scores and the poverty levels of states and UTs as measured by the Multidimensional Poverty Index recently released by the NITI Aayog. This is the composite index scores in reference year 19-20 and multidimensional poverty index scores. On the right bottom, you see Bihar. On the left top, you're seeing Kerala. That is the diversity of India. And the worst poverty index is in Bihar. The best is in Kerala. And nearby Kerala, you find Tamil Nadu on the left top, and Chhattisgarh also, Himachal also you find on the left top. Next slide. There's a composite index scores per capita net state domestic product at current prices. And you find on the right side, you find Delhi, Sikkim, and Gujarat. On the left bottom, you find Bihar with the lowest per capita net state domestic product at current prices in 1920. And UP is nearby Bihar. Next slide, please. The health index is a useful tool to measure and compare the overall performance and incremental performance across states and UTs over time, and nudging the states and UTs to shift the focus from inputs and outputs to outcomes. The health index has strengthened the culture of use of data at the state and UT level to monitor performance and is contributing to the agenda of improving availability, quality, and timeliness of data. Now, let's look at one important aspect. All you need to know about the new labor codes. 4 new labor codes are likely to be implemented in 2022-23. With labor being concurrent subject, states are in the process of pre-publishing draft rules for these reforms that will be a key driver of improving the ease of doing business in the country. Next slide, please. What are the new labor codes all about? The new labor codes are aimed at facilitating ease of doing business in the country and seek to replace 29 cumbersome codes. The objective is to encompass over 500 million organized and unorganized work sector workers, 90% of the workforce which has been outside labor laws. The idea is to ensure that they receive wage security, social security and health security, gender equality in terms of remuneration and minimum floor wage, make the lives of interstate migrant workers easier, add 15-day wages for reskilling workers during retrenchment. Second is, what is the current status of the codes? The 4 codes, that is the Code on Wages, Industrial Relations Code, Social Security Code, and the Occupational Safety, Health and Working Conditions Code are likely to be implemented in financial year 23. While the central government has completed the process of finalizing the draft rules, state governments are in the process of drafting the same. 24 states have pre-published the draft rules for the Code on Wages, 20 states for Industrial Relations Code, 18 states for the Social Security Code, and 13 states for Occupational Safety, Health and Working Conditions Code. How many labor laws do Indian states have? The simplification of 29 labor laws into 4 labor codes is expected to be a watershed moment for labor reforms. India currently has a web of multiple labor legislations, over 40 central laws, and 100 state laws involving labor. The second National Commission on Labor in 2002 recommended simplification to bring about transparency and uniformity. What are the major goals in these codes? With organized sector workers being approximately 10% of the total workforce, the new codes may ensure that social security benefits are for all. As per the proposed labor codes, total allowances such as house rent, leave, travel, etc. are to be capped at 50% of salary, while basic pay should account for the remaining 50%. This will result in lower take-home salaries for a certain section, but will increase contribution to retirement funds. There could also be a permissible 4-day work week of 12 hours per day. How will it affect ease of doing business? Labor productivity is likely to improve with both employees and employers developing a sense of being partners in wealth creation. A transparent environment in terms of workers' compensation, clear definition of employee rights and employer duties, and simplified labor codes making compliance easier are likely to attract investment. With more workers in the organized sector, leakage in terms of direct as well as indirect taxes may be plugged. And this is as a result of the study by Jagdish Shettigar. One of the important paper which has been published in the Global Journal is Organizational Best Practices Supporting Mental Health in the Workplace. To provide a narrative review of best and promising practices for achieving exemplary mental health in the workplace as the foundation for the inaugural Caroline C. Mattingly Award for Mental Health in the Workplace. The study carried out this review. It provided scientific backing to support criteria developed for the Caroline C. Mattingly Award for Mental Health in the Workplace. By recognizing organizations that apply evidence-based practices in their health and well-being program, the Mattingly Award may inspire employers to adopt best practice. Let's look at the best practices, this paradigm. What is the scientific backing that's for this criteria? Next slide, please. This study came from the Department of Mental Health, Johns Hopkins Bloomberg School of Public Health, Baltimore, Institute of Health and Productivity Studies, Johns Hopkins Bloomberg School of Public Health, Baltimore, and independent consultant of Northern Ireland, UK. The human and financial consequences of poor mental health at the workplace impose a heavy burden on employers and workers alike. Evidence-based organizational programs, policies, and environmental supports from the foundation for the Mattingly Award for Mental Health in the Workplace to encourage organizations to adopt positive cultures of health. Next slide. The mental health and well-being of employees have become an increasing concern among employers, especially in response to the COVID-19 pandemic. Over a year after the virus was first discovered, employees continue to fear that they will be exposed to or spread the disease to family members, co-workers, friends, or strangers with whom they come in contact. Additional pandemic-related stressors, including high ambiguity and uncertainty, social isolation due to physical distancing measures, changes in both work and domestic responsibilities, and concerns regarding financial and job security have further affected employee mental health. According to a recent survey conducted during the COVID-19 pandemic, workers reported an increase in mental health symptoms, including heightened feelings of guilt, 24%, insomnia, 38%, irritability, 50%, sadness, 53%, and emotional exhaustion, 54%. This is the criteria for Mattingly Award recognition. You find categories are culture, robust mental health benefits, employer sponsored health resources, workplace policy practice, healthy work environment, leadership, positive outcomes, and for all these dimensions, the categories have description for each. Like for culture, it is positive organizational culture that supports employee mental health. For example, building mental health into the organizational human capital strategy, governance and leadership emphasis on employee psychological well-being, including mental health in organizational communication materials. If you look at workplace policies and practices, the factors are safety, ergonomics practices. Second, programs and policies to prevent sexual harassment, discrimination, workplace violence, and bullying and incivility. And third is comprehensive efforts to promote diversity, equity, and inclusion. So this way, this provides a model for applying evidence-based criteria for developing mental health in the organizational workplace. Next slide. Sorry, because of network, I got disconnected, but here we are again. Promoting positive mental health in the workplace is a complex process that requires collaboration across several leadership levels. While work can play a positive role in contributing to worker well-being, it can also become harmful and toxic when there is a lack of social support and unhealthy organizational culture. Therefore, by recognizing employers that put in place intentional efforts to protect the well-being of their workers and promote a culture of health, the Mattingly Award hopes to inspire more organizations to adopt best practices in mental health for their own employees. The journal was Journal of Occupational and Environmental Medicine, JOEM, which is the highest ranking journal in occupational and environmental health in the world. Next slide. Yes, now we take an overview of 3 conferences that are going to be organized in January, February, and March 2022. First and foremost is the 9th Global Conclave of AEOHD, that is OCCLave 2022, which will be held on Saturday 26th and Sunday 27th of March 2022 in Scope Convention Center, Scope Complex, Lodi Road, New Delhi. The theme for this conference will be fostering health, well-being, and environmental sustainability for future and future-ready organizations. Next slide. The registration for AOHD members is 1,000 rupees, and for non-AOHD members is 5,000 rupees. You can register at the address given in the slide, and there will be registration available online as well. Second conference of importance will be held in January, that is 21 to 23rd January 2022, that is OCUCON, 72nd National Conference of IAOH, Indian Association of Occupational Health. The theme will be Occupational Health Physician as a key management person, that is KMP, for a healthy and sustainable growth of organization. Last date for abstract submission is 8th of January 2022, and abstract sub-themes posters selected for the presentation will be virtual mode during the allotted time. The presentation will be on virtual mode during allotted time. Time for each scientific paper presentation will be restricted to 8 minutes, and there are a wide range of themes and sub-themes you can submit your abstracts on. The third and the most important event that is going to happen in 2022 February, from 6th to 10th February 2022 in a virtual mode, will be the 33rd International Congress on Occupational Health. 2 stages for a great digital experience, Melbourne and Rome. There will be one stage in Melbourne, other stage will be in Rome, but totally digital Congress. The theme will be sharing solutions in occupational health through and beyond the pandemic. 6th to 10th February 2022. Next slide. The registration is still open till 10th of February, and there is a difference of fees in ICO for ICO members and ICO non-members and students and other countries. And if you are belonging to low and middle income countries, they're different rate. If you belong to high income country, you have a different rate. Next slide. There will be a galaxy of global keynote speakers and plenary keynote speakers, including Soumya Swaminathan, who's the chief scientist in WHO. Next slide. Abstracts have now closed, and all abstracts are in the process of being submitted. The posters are to be submitted by 3rd of January 2022 for the persons whose posters have been accepted for presentation. Next slide. So here we come to the end of this session of OKU Healthscapes. But before we end, let's look at the positive side. Let's hear the two important videos. First will be the World Health Assembly video, and second will be the video for 2022, welcoming year 2022. The first look at the World Health Assembly video, and then we can end and have the discussion thereafter. Shivan, first play the World Health Assembly video.
The world has come together before to dispel the temptations of isolationism and nationalism, to address the challenges that could only be achieved together in the spirit of solidarity and cooperation for peace, prosperity, health, and security. The COVID-19 pandemic is one of the biggest challenges we are facing. It's been a stark and painful reminder that nobody is safe until everyone is safe. There will be other pandemics and other major health emergencies. No single government or multilateral agency can address this threat alone. Together, we must be better prepared to predict, prevent, detect, assess, and effectively respond to pandemics in a highly coordinated fashion. The 194 member states of the World Health Organization resolved to work together towards a new international instrument for pandemic preparedness and response. This renewed collective commitment is a milestone in stepping up pandemic preparedness at the highest political level. Such an agreement, rooted in the World Health Organization Constitution, could strengthen existing international health instruments, especially the international health regulations, and provide a firm and tested foundation on which we can build and improve. The agreement also has the potential to foster an all-of-government and all-of-society approach, strengthening national, regional, and global capacities and resilience to future pandemics. This could include greatly enhancing international cooperation to improve alert systems, data sharing, research, and local, regional, and global production and distribution of medical public health countermeasures such as vaccines, diagnostics, and personal protective equipment. The agreement could also recognize the One Health approach that connects the health of humans, animals, and our planet. To achieve this, WHO will support its member states in their work and facilitate the involvement of relevant stakeholders, including from civil society and the private sector. Pandemic preparedness needs global leadership for a global health system fit for this millennium. To make this commitment a reality, we must be guided by solidarity, fairness, transparency, inclusiveness, and equity.
That's the foundation for 2022. Now we should welcome 2022 with music and a little song. Let's hear the music to relax and to welcome 2022 tonight. So it's taking a little time, but I hope the wait is worth its effort.
No more champagne and the fireworks are through. Here we are, me and you, feeling lost and feeling blue. It's the end of the party and the morning seems so gray, so unlike yesterday. Now's the time for us to say Happy New Year, Happy New Year. May we all have a vision now and then of a world where every neighbor is a friend. Happy New Year, Happy New Year. May we all
Well, I wish
have a host.
all a very happy new year 2022. Thanks for your patient listening.
Sir, I would like to just add in here, as usual. You exceeded the expectations in delivering the diversified deliverables for the session. As always, videos were impactful, wonderful. Now, floor is open to questions. There are appreciation messages for Dr. Jain. It's directly from the heart, I know. I echo the same for you, sir. Your passion, dedication to the subject is unparalleled. We are really blessed to have you in India. And there is one statement by Dr. Samir Chaudhary. He says male literacy has a more role to play in fertility rate and should also be a part of indicators to identify challenges in population growth. So do
Well,
you want to comment?
I would agree with this, but to some extent. But the major change maker in fertility is women, and her literacy has far bigger impact than male literacy. That has been the experience globally, not only in developing countries, in developed countries as well. So it is not to underscore men literacy, but if it comes to fertility, women literacy has a far more impactful contribution.
Agree with you, sir. So there are no more questions actually, or no comments anywhere, no hands up. So I think we are all coming to the end of the session. I take this opportunity to thank organizers for allowing me to moderate this educative session today. As a special note, my hearty congratulations and best wishes to Dr. Gajendra Kumar, President IAOH Delhi branch, happens to superannuate from services in railways today and start new phase of life from tomorrow. And I would like to congratulate and thank Dr. Sandeep Sharma, Secretary IAOH Delhi branch, all supporting members of IAOH, Dr. Shyam Pingle, Dr. Tyagaraju, Dr. Shiva, and invited speakers and moderators of all the sessions of DigiConnect series till now, Shivang Vasisht and the Secretariat of IAOH Delhi branch for efficiently managing behind the screen activities. Most importantly, Dr. Rajiv Kumar Jain, soul of the webinar series, for all his hard work to provide us comprehensive updates on local, regional, global, environmental, and occupational health news with his insights. I thank all of you participants of the session and wish you all a very happy, prosperous New Year 2022. Invest in health to stay safe and enjoy life. Thank you once again.
Thank you so much. Very happy New Year to all.
Happy New Year, sir.
Happy New Year to all.